appreciate that so much. And the Hope and Healing Center has just been so good to me. And the fellowship that I received was to help me write the NeuroWhereAbouts guide, which is written in infographic style, really colorful. No page is the same as the other, with lots of information about how to protect a healthy brain as children grow, and information about how to talk to kids about 18 different high-risk behaviors. I put the link in the chat. It just literally came out on Amazon last month at the end of the month. And so it's really cool to be able to talk about it. But let me share with you the screen for the presentation we're going to do today. And I just kind of put this together from a lot of my other presentations. And so I have the notes slides for you guys. So you'll have to email me. I can also send them to Cody, but please feel free to email me at the end, and we'll make sure to get those to you. And then Cody, I keep seeing this message. People are waiting. Are you admitting people? Okay, cool, good. All right, so today we're going to be specifically talking about dual diagnosis. And I'm going to keep an eye on the chat. I see that there, okay, hold on, there we go. There it is. I'm gonna try to keep the chat up. Nope, I can't get the chat to be up on my screen, so I'll have to go back to it. But you could also, if you have a question, feel free to put it in the chat. If it is a short question, feel free to unmute and ask. I'd be happy to discuss those as I go. But we're going to be talking about dual diagnosis, which is actually an old term. It's now referred to as co-occurring illness with addiction and mental illness. And so I'm going to share with you guys some of my experience. I am an addiction specialist, but I also am a therapist, and I've worked with people my entire career who have mental health issues and substance use issues. And I don't think that I've ever worked with a client that just had one and not the other. So I think a lot of times my job is to help them figure out which one came first. And so let me give you some overview of what we know is that substance use disorders go hand in hand with a few issues that are commonly co-occurringly diagnosed. The one at the top, antisocial personality disorder, is more rare, but it definitely goes hand in hand. Depressive symptoms, anxiety symptoms, phobias also are extremely common, and trauma. And depending upon the conglomeration of symptoms that we might have, they predict poorer treatment outcomes, which makes sense. The more diagnoses you have, the more issues that are going on, the harder it will be for you in treatment, and the more difficult time that you might have healing from that. So I make up that my audience today is a lot of clinicians, and hopefully some parents and loved ones, so I'm going to be speaking to both of you guys, clinicians that treat as well as loved ones who have family members that they're concerned about. A few brief statistics is about 42.8%. That's almost 9 million adults with substance use disorder also have a co-occurring mental illness. So like I said, I have not ever met someone who just had one issue. Most people that I work with who have substance use disorders deal with anxiety and depression in different ways than people who just have anxiety and depression, and that they've dealt with that before. So we're going to talk about genes. But here's a couple of things that are important to remember is that about 60% of these women and 30% of these men report a history of physical trauma. About 47% of women and 17% of these men also reported a history of sexual trauma. Very, very common. So what I always found interesting as a therapist is that up until 3 years ago, most master's degree programs had an addiction class available to students, but it was an elective. And that means if you never took addiction, you as a therapist really missed a huge piece of information when treating other people. And so it scares me a little bit. So I'm seeing some, let's see, I've got some noise coming in. Angela, could you mute yourself? Do you mind? I can see that. Thank you, guys. Okay, so what we know is that there's a lot of clinicians out there that may have a lot of experience with mental health issues, but no experience with addiction. And so it's very important to make sure that you understand the underlying issues. I find myself going head to head with a lot of psychiatrists and different folks who really have a lot of mental health experience, but not a lot of SUDS experience. And they want to treat things with medications and this and that, which I know have negative effects on people who are suffering from substance use. So we'll kind of discuss treatment about that in a second. About 60 to 70% of women enrolled in SUDS treatment report a history of partner violence, compared with 25% of women in the general population. So this makes it incumbent upon us to make sure that we assess all these areas when we're also assessing somebody for SUDS. Women are more likely to experience sexual trauma, but men are more likely to experience physical trauma as kids. And so a lot of times what I see on a standard intake form is information about substance use and mental health diagnostic history, but sometimes I don't even see an area that can help assess for trauma. We got to make sure that we don't assume that just because they're a man that they necessarily haven't experienced some type of trauma as a kid, which is an assumption I see a lot of my interns make. So we've got to make sure that we ask about adverse childhood experiences. And this is the pyramid that helps describe the types of ACEs that we see. That I got this from the actual ACEs website, which is a beautiful repository of research on adverse childhood experiences, by the way. If you've not been to that website, I highly suggest that you go. And so kids deal with a lot of different negative events. Disrupted neurodevelopment, attachment wounds, social and emotional cognitive impairment, learning difficulties, adoption, stress, chronic stress, poverty, disease, disability, social problems, parents that have alcoholism or drug addiction, physically abusing, sexually abusing, as well as early death of loved ones within their family system. We need to make sure that we assess this very accurately and thoroughly when we're doing intakes with our clients. So here's, it looks like I've got a red mark here that I don't know how to get rid of. Sorry about that, you guys, but this is just a short list of traumas and wounds that I see. And so I always want to make sure that I use the word trauma very carefully, because it is very stigmatized in our culture, especially men. Men will say to me, oh, I don't have any traumas. And yet I know this person has been to Vietnam twice. I'm thinking, okay, what words can I use to create this? So I use the word wounds a lot, or I use big T, little t. So big trauma, big T, would be something that somebody might consider as huge, as traumatic. But then there are a lot of wounds or little t's that may stay with us for long periods of time. And this is just a short list of some of them that I have seen with clients and worked on over time. So child maltreatment is associated with severe alcohol and drug dependence. And so if you are working with a client who says that they grew up with an alcoholic parent, always make sure you asked about neglect. And many times what you see is trauma bonds, is kids who don't want to tell on their parents, who feel guilty about talking about their parents in a negative light. Oh, well, they drank a lot, but they cared for me, they did this. So sometimes making sure that you validate all the wonderful things that they experienced, but also educate them on what it means to be an ACA kid. For those of you guys who don't know what ACA kid means, that is an adult child of an alcoholic. And so what we know is that greater high school dropouts, more frequent alcohol and substance abuse, and earlier ages of dependency begin with kids who have parents who have alcohol and drug histories. So the big question here is why? So it's interesting because I've studied the prevalence rates of alcohol and drug use. And we know the younger someone starts, the worse consequences that it has for them as they grow and develop throughout their brain and their life, especially with areas in their life that have been affected by that. But why is it that some kids see their parents using drugs or alcohol and they say, nope, I'm not going to do that? And a larger majority of kids end up very similar to that. So we're going to answer that question in this presentation. And the way that we tackle that is by really understanding family of origin issues, which are the core wounds that fuel addiction and potentially also have a role in mental health issues. So if anybody has seen this poster, you can find this online. I have this printed in my office in a large poster size, and I also have a stack of these printed because I want my clients to be able to take them with them as they go. So important to remember that family systems where there is alcoholism, drug addiction, or mental health issues create a role. The role that has been labeled for this is the victim role, and these are the guys right here in the middle. This poster depicts what it might look like for a family who deals with somebody who's chemical dependent. But what I find is that in family systems where there's mental health issues and substance use issues, there's always somebody that is in this victim role, whether they play that role, see themselves as a victim, or truly are a victim of an illness or a disease or life circumstances. And that is the person that the rest of the family rotates around. It is where we direct energy as well as kind of lose energy from this role. This shows you what they look like on the outside, and sometimes they may be very aggressive, or it could be they may be very charming. They may be full of self-pity or blaming or hostility. They may be manipulative, but on the outside, on the inside, they feel a lot of shame and guilt and fear and pain and hurt. So in my family of origin, I grew up with a parent who struggles with mental health issues herself. And I remember her playing really this role when it came to her talking about her parents. And when I went to go visit my grandparents, it was always a very stressful event being there with them. I could feel the tension in the house. I didn't quite know what that was about, but I would listen to my mom talk about how upset she was at how she was treated, how she was not protected by her parents, by her from her brothers, by her parents. There was quite a lot of sadness within my mom at that time that I could feel as a little kid growing up. I remember feeling sad and sorry for her and wanting to take really good care of her. And when I asked her one time, Mom, why did you have kids? She said, oh, honey, I had you because I wanted somebody to love me unconditionally. And I remember thinking at the time she told me that, I was little, that is awesome. I am going to be the person who loves you more than anybody else. And of course, I, as you guys can see, took on the family hero role. I'm the only child of a single parent, and I caretake. I took very good care of my mom. And so on the outside, I was, looks like these, yeah, there we go. On the outside, I was that good kid, that high achiever. I was working really hard. I remember having this anxiety of listening for the garage door to open and wondering if my mom was going to spot something that I didn't do, because that was her MO, was to cue in on the thing I didn't do and say things like, Crystal, how could you do that? What is wrong with you? On the inside, I felt a lot of shame, guilt, hurt, and insecurity. I remember thinking, I thought, if you would only tell me what's wrong with me, Mom, I will fix that for you. I remember having that thought as I grew up. Well, if you are a sibling, you may relate to some of these other roles that show up in a addicted family system. But remember, this can also be the dynamics of a family system where there is mental illness or both. One of the people that is usually closest to the victim is our chief enabler, who is usually the person who takes care of the victim role. And on the outside, they're usually very super responsible, self-righteous maybe. A lot of times this person gets sick a lot or has a lot of complaints because they don't take very good care of themselves because they're taking care of everybody else. They may feel very angry, have low self-worth, have guilt and hurt. And so the kids in the family, the other siblings, may take on a couple other roles. The mascot role, which is a quintessential role that was very common for an actor, Robin Williams. You guys may remember, rest in peace, Robin. He played the mascot role in his family. He was the cute one, the funny one, and that is the role that the mascot plays, is to take the focus off the victim by being the funny and the cute one. But on the inside, they suffer a lot of anxiety and a lot of fear and insecurities. The family hero's role is to be the kid that everybody can point to and say, hey, we're okay because we've got her, we got him, she'll take care of everything, she's our star. Then we have the opposite of our family hero, our scapegoat role. This might be the problem child, the one on the outside that looks very defiant, breaks all the rules, is always in trouble. This is the one that also takes the focus off of the victim by being the problem in the family. When the chemically dependent or the mentally unhealthy person points the finger at the scapegoat, then they don't have to point the finger back at themselves. Our scapegoats deal with a lot of rejection and hurt, jealousy of their siblings, and anger. And then there's our lost child. Of course, I saved her for last. This is the kid who no one has to worry about in the family. I remember doing a family session with a family of 5 kids, mom and dad. The dad had sex addiction, alcoholism, and lots of depression. And we went around the room and asked everybody in the family to share their experience being around dad when he was in his different moods and roles. And they got to the very end with this really sweet kid who was kind of hanging his feet off the chair. He couldn't quite touch the ground and he was looking down the whole time. When I asked him to share his experience, 3 people in the family spoke up and said, oh, he doesn't need to talk. Like, we know how he feels. He's totally okay. And I remember watching him look at his family members talking, and then he just went and looked down. It made me really sad because he plays the lost child role in the family and they need him to be okay. And so on the outside, they may be the shy or quiet kid, and they may also look like they have it all together, or kind of tune into things rather than people. They may get lost in pets or animals or video games or reading. But in the inside, they feel a lot of hurt and rejection and maybe get quite anxious. And so I really love to utilize this poster in family sessions to help people identify what their roles might be. And let me share with you, in a healthy family system, these roles exist, but they're flexible. We may try on these roles a little bit as we grow and develop until we find our authentic self in the family and create healthy roles. But in unhealthy family systems where there's chronic mental illness or chronic substance use, what we see is these roles become rigid and fixed. And so let's see, Diane says, can a child change roles or bounce between 2 of them? Yes. At a family many years ago with 2 kids in the family, and we had neglectful absent parents due to wealth and attachment issues. They were always gone, and they had nannies that took care of their kids growing up. One year, the girl would be the scapegoat and just really let school go while her brother was the family hero and made all A's. The very next year, they would switch. And when I brought out the family poster, they both talked about that and talked about that both of their parents had played the victim role and enabled each other to do that, and how much they missed their parents and the attention that they tried to get from their parents by trying to either be the best kid or the worst kid in the family. Definitely, we can see that switch. What I also have seen and has experienced that on my own as well is when there's a death in the family, or there is somebody who maybe gets sober or in recovery and starts to estrange or distance from the system, is to see someone else fill a different role. So the middle child may start to fill the family hero role if that family hero is absent. I actually used to be the family hero in my family of origin, but then as somebody in the family died and the dynamics switched over, I actually became the scapegoat in the family. So now I'm the one who people are mad at and don't talk to, which is really a weird experience for me, having been the family hero. So it says here, another question: how do you know which to treat, the mental health or the substance use? So we're going to get into that and definitely talk about that too. So you've got to figure out, first of all, what came first. And that's why I'm talking about family of origin, because we really want to understand what a person's family of origin was like, what their genetics were, what their attachment styles were, what their parents' styles were, so we can understand what happened. Family systems like the one that I just discussed can create anxiety, depression, trauma, and a lot of the things that cause mental health issues. So we want to assess that so we can figure out, did that come first? Was it something that was already there and present, potentially genetically or trait-wise? Or did their mental illness, was their mental illness born within a dysfunctional or an unhealthy family system? So here is a handout that I found a few years ago that gives you the dysfunctional family rules. I like to say unhealthy family rules: don't talk, don't trust, don't feel, and don't deal. Lots of control, be perfectionistic, don't talk about what's going on in our family with anyone else, look on the bright side, there's not a problem. Incomplete. I remember my mother telling me how bad it was in her family growing up, and that I've got it good. And I remember thinking, is this good? Right? Feeling really invalidated about my own experience within that. So I think teaching your clients and asking and assessing your clients, what were the family rules in your family? Did you guys value talking, trusting, dealing, feeling, openly discussing what's going on with people in your home? Or was it swept under the rug? Or were you gaslighted? Were you blamed? What was going on? Sometimes showing them rules like this can be really empowering to say, yes, that's exactly what happened in my family. We denied all of our feelings and thoughts and perceptions and weren't really allowed to have feelings about that. So Julia says, I can understand that someone may switch from one role to another. Is it possible the victim may be subject to the split personality? So if you're talking about dissociative identity disorder, which is actually quite rare, it's possible, most definitely, that the victim, and remember that's just a role, could be somebody that legitimately has mental illness. They may be the victim of that mental illness. Of course, a lot of people don't like to use that word victim, but I like to discuss it because I think there is a lot of power in playing that victim role. And it can also be quite debilitating to be a victim of substance use or mental health issues. Okay, so let me keep going here. These are some of the effects that I have seen on people who deal with addicted family systems. Just a few of the coping mechanisms that we might learn or the effects of it. So a lot of times what you see in an addicted family system or a system where there's dual diagnosis, if you have a parent who is suffering from trauma or mental illness and who also is using substances, what you see in the kids is that they learn how to cope. I learned how by being the family hero and doing everything perfectly. I see that a lot of kids learn by dissociating and checking out. I see a lot of kids figure out how to communicate in very passive aggressive ways to learn how to survive in their family system. What I love to do is see that in a positive light. is that those kids learned how to adapt. They learned how to figure out to survive in that family system. Now, here's the rub. When we learn these unhealthy coping mechanisms as kids and we take those into our adult lives, they don't work very well. So as a family hero, I married somebody who has a critical mom button. Go figure. And a lot of times when he is upset in our marriage, he withdraws. And what that makes me do is want to get busier and to be more perfect or to get more things done. And that just really hurts and invalidates him even more. And so my old coping mechanism of trying to be perfect and do things right and fix things actually walks on his boundaries and invalidates him. So I have really had to learn very, very hard on my own time to not act out that old family of origin coping mechanism, to change those long strings of neurons in my brain for something that's healthier and more adaptive. Okay, so we're going to talk a little bit about arrested development because you guys know I study the brain and how this affects people as they grow and develop. So I want you to imagine either you or your family member as a child, as they grow and develop, what you're dealing with in your family system actually changes the trajectory of your brain. The part of the brain that I've studied the most has been this stage, the second phase of brain development from 11 to 25, when we're actually losing neurons, but we're growing connectors. We start off with 200 billion neurons, and by the time our brain is grown, we have 100 billion left over. But it's important to remember what's happening during that stage. We're growing myelin, this fatty tissue that covers our axons. As it grows and develops, we actually become better processors, faster processors, because myelin helps the electrical impulse move down the cell faster and faster and faster. Another thing that's growing are dendrites, which are those beautiful things that reach out at the ends of our neurons, connecting to other neurons. So as our brain is connecting based upon what skills we're using, this is what it looks like. This is a picture of a baby neuron. And as that infant neuron starts to grow and develop, you can see that it thickens and those dendrites are reaching out to other neurons. This is at age 2. And what we see at the end of that is that these neuronal connections are actually the skills that we're using. So if we learn don't talk, don't trust, don't feel, don't deal, we actually grow neuronal structure for that way of being in the world. That can result in having mental health, mental illness, and substance use issues. So these can also affect the growing brain as it's developing if they start then. If we start to experience trauma, adverse childhood experiences, if we have a wound in our attachments with our parents, if our parents used a style that was not very healthy for us, if we experience death or loss or chronic stress during this time, it can affect our brain development in the exact same way that early substance use can affect it. And that's because of the principle use it or lose it. The cells that we're using are the cells that make those long strings of connections. The ones that we don't literally get pruned away to make room for that new structure, those dendrites and the myelin. This is what is extremely important to remember is the outcome of a fully developed and functioning frontal lobe. And that is the early, what the scientists call lower level executive functioning skills that we see start to come online in middle school, and then or up to elementary middle. Then we get to middle school, high school, and throughout, we see our higher level executive functioning skills are starting to grow and develop. What we know is that any type of trauma, adverse childhood event, or substance use has the power to arrest the development of these skills, then causing somebody who doesn't have the skill set to be able to deal with what's going on as an adult in the same way that they would have been able to have their brain developed in a healthier way. Now, I've studied how trauma and drugs and alcohol affect the brain during this process. Nicole, would you mute, please? Thank you. And it goes back to our limbic system, the fight, flight, or survival part. This is the part of the brain that is affected by trauma and substance use. Specifically, if you think about the two jobs that the limbic system has, is to keep us alive and for us to experience pleasure. We're affecting both of those with mental health issues and substance use. When we talk about substance use, we are talking about the neurotransmitter dopamine that makes us feel calm and happy and signals salience. Like when we're doing something that is salient, it's good for our survival. So when we eat, we get 100% increase in dopamine. When we have sex, we get 150% increase. When we smile, when we connect with people, it's amazing to me that the brain knows exactly what's good for our survival and gives us a little increase of dopamine to tell us that we're on the right track. Even exercising increases dopamine. I wish that I could do that more regularly to get that dopamine hit, but there are things in the world that spike dopamine levels too high. Things like cocaine, which gives a 350% increase, meth, which is an 1100% increase, heroin is 1300% increase. And what is it doing to our brain? If we travel deep inside the limbic system, this is what we're going to see. Actually, let me, I can't, I had a video ready, but I can't get it to load. If we travel deep inside the limbic system, what we see is that too much dopamine that goes above our threshold, which is this black line here, actually causes our brain to grow new neuronal structure. That neuronal structure comes in the form of more and more receptor sites. When we create more receptor sites in our brain for dopamine, there is this moment in time when we have one too many receptor sites. And now when the drug leaves our system, we start to have cravings, build a tolerance, and go into withdrawal. But every brain is different. So this black line indicates the hedonic threshold, which is the pleasure threshold for dopamine in most everyone's brain. We go up and down, as this blue line indicates, all day, every day within that threshold. That's normal. When we are hungry, our dopamine plummets. When we're lonely, it plummets. When we eat, it goes back up. When we interact with people, it goes back up. It's just our brain telling us what we need to do to survive. When we engage in substance use or an addictive behavior that spikes dopamine levels higher than our threshold, that's when the structural changes start to occur. We see this in substances such as alcohol and drugs and food, as well as addictive behavior like gambling, video game addiction, technology overuse, and so forth. If you have any genetic history in your family, your threshold is most not likely this black line. It's more likely the red line. What we know is that there is a lack of dopamine in many genetic predisposed individuals. Think about it. You have genes that tell your body to do certain things. I have a gene that tells my body to have green eyes. I also have a gene that tells my brain how much dopamine to make. But because I have the genes that have morphed a little bit and passed down from my family members that tell my brain to make less dopamine than other people, I have something called reward deficiency syndrome. And it's very easy to get a genetics test. I have that information at the end so that you know that. If you make a little bit less dopamine, you may feel a little bit less pleasure in life, feel a little uncomfortable in your own skin. That may cause you to have depression, anxiety, but it also may cause you to reach out for substances that inflate the amount of dopamine in the system. This is what it looks like from the top down when we are scared, when we have trauma, when we have something that's chronically causing stress in our life. The top brain is of somebody who's completely healthy, safe, sober. All the parts of the brain are on. There's electrical activity and blood flowing everywhere. The bottom is actually a picture of somebody who has used substances, but it is also a picture of somebody who is in chronic fear or they're going through a trauma. Your limbic system kicks on either because it's full of dopamine from pleasure or because it's scared and it's in fight or flight. When it does either one of those, it turns off the frontal lobe. It sends that energy into the limbic system to either process the drug or alcohol or help you survive the trauma. If this happens to you chronically, or you start using substances between the ages of 11 and 25, it can cause your frontal lobe to arrest. And remember, your frontal lobe is where all those executive functioning skills that you need to adult grow. So if you start using here, or if you start experiencing an adverse childhood event, it could actually shut off this frontal lobe growth. By the time that you're 20, if you've been using substances or experiencing trauma, your brain, your frontal lobe, most likely will not look like that one. It may look more like this one or the one over here at age 12. That's why it's really important to make sure that we try to help families function, reduce chronic stress, and eliminate substance use, so that not only can they function as a healthy family, but so that children's brain development can go on unfettered. It takes a long time to heal. This is a beautiful study that illustrates a cocaine abuser 10 days sober, and then another picture of that same person 100 days sober. You can see the frontal lobe is really starting to turn back on here. But think about what we've been going through in this stressful pandemic. Our brains have been functioning at this level, not because of cocaine, but because a lot of the stress that we're under. That's why our bandwidths feel shorter, because they really are. When we have chronic stress, our limbic system is chronically in the on mode, but our frontal lobe has moved that energy to our limbic system to help us deal with that threat, rather than being able to help us calm down and deal with life. Now, here's what's quite interesting. When this happens over time because of alcohol or drugs, we get a state that physicians have nicknamed acquired narcissism. When I first heard this term, I was at an addiction conference and I heard doctors talking about this, and I Googled it, and I found all this information on pop stars that make it big and then they forget all the people that they loved at home. Well, this is something that really illustrates what happens when your frontal lobe is off all the time. You actually have a very difficult time attuning, appraising yourself, reflecting. You have little capacity to connect to others, and so you may project onto them. Difficulty controlling your impulses. You focus on yourself and the drug or the alcohol or mental health issue that's going on with you, and you may have lots of moodiness and extremes and be in lots of denial. If you are parenting in this state, whether it's caused by mental health problems or substance use issues, you can tell you're probably not the most effective parent and can cause trauma to the kids that you are dealing and working with. So I've worked with lots of families over the years, one in particular, an adult child, and her mom came to visit me, and they told me about their dad, who had been in drinking for the past 10 years. He had not drank when he was young because he saw his dad drink, and so he decided to not do it. But when he sold his business and didn't have much to do at an early age, he started drinking, turning his frontal lobe off on a daily basis because he was constantly drinking alcohol every day. And what they noticed is over the period of a decade, he changed from this wonderful, loving, considerate man into something that looked very much like this. When I pulled this sheet out in my session, they started to cry and said, yeah, this is him. And the good news is that we got him into a treatment program, and after about 18 months to about 2 years, these went away because we were able to go back to his frontal lobe functioning at the rate that it did prior to that. It was a frontal lobe that had grown all the way through development with no alcohol use. But then what we saw is that when he was able to recover, he was able to connect with his family again. For people who have arrested development from addiction, once they get into recovery and get sober, now we have to train those executive functioning skills that they didn't get because of the arrested development. So here's another thing that we want to make sure that we think about is, I love this poster. Stress is dessert spelled backwards. And when we are stressed, what happens is cortisol, the stress hormone, increases in our system. Well, what's cortisol's job? Cortisol's job is to dampen the effect of dopamine, because we can't be all calm and relaxed all the time. We're supposed to be a little on edge so we can get the stressor out of our lives. But what that does is it dampens dopamine in our system. When we have dampened dopamine, guess what? We crave dopamine. We crave dopamine from the thing that spiked dopamine the most. For me, it was intravenous cocaine use. I cannot intravenously use cocaine anymore. And so what's the next best thing? Potato chips and chocolate. These are things that we crave when we get stressed. But what if the stress is caused by chronic issues? Stress equals cortisol equals dopamine. Low dopamine equals cravings. Stress and cortisol play a major role in relapse and in long-term health issues. What we've seen is that not only does high cortisol cause food cravings, but it causes weight gain, diabetes, high blood sugar, heart problems, inflammation, brain fog, irritability, mental health problems like increased depression, chronic anxiety, stomach ulcers, premature aging. What we want to make sure that we focus in on in recovery is reducing stress and learning how to reduce cortisol in natural, healthy ways. So, PTSD and substance use, high levels of mistrust toward treatment providers. Kids who have a lot of adverse effects, veterans who have a lot of PTSD, a lot of clients that I've worked with who have attachment wounds with family of origin, parents that neglected, abandoned, or emotionally abused them, have a lot of mistrust toward treatment providers. They engage in treatment less and have higher recidivism rates regarding their substance use and relapse of their symptoms. Also have higher levels of aggression, hyperarousal, avoidance, and they re-experience the trauma more often. So when we as clinicians think about stress, we want to make sure that we assess this accurately in our intake and address it throughout our treatment with clients who have mental health issues or substance use issues or both. There are lots of different sources of stress. We want to look at attachment, family of origin, alienation, trust issues, any withdrawal, because withdrawal is a really great way to avoid and keep yourself alive and healthy in a dysfunctional, unhealthy system, but it doesn't work really well as adults. We need to connect in order to get healthy. So we want to make sure that we address all of these potential sources of stress when we're working with family members and clients. And if you are a loved one of somebody who has dual diagnosis, you are not responsible for reducing their stress, but you are responsible for engaging in treatment with them. Like, for instance, going to family therapy or couples therapy with your partner. Okay, so I know I'm talking pretty fast, but I want to make sure I get through all of my slides so that we can answer more questions. So I always think about prevention and recovery as this picture, lots of neurons that are growing. We grow dendrites for the rest of our lives. Thank God, we can still learn. Dendrites are the hardware of learning in our brain. And so as we grow new structure, what we want to think about is how do we get better from mental health issues and substance use issues, especially if we have both? Well, first of all, we want to work on the basics. How do we feel? How can we identify? Remember, feelings are not facts, but they give us information. So we need to be able to identify the feelings so that we can tackle the source of the feeling. And I find that a lot of people who have dual diagnosis issues are really terrible at this, because they just don't get to learn how to identify the feeling, where it is held in the body, and what it means. Remember, they're not facts, but they give us information. So first, you can use a feeling wheel to help you identify that. I have one of those, a feeling wall in my book. You can figure out, this I love because it looks like a color wheel with the primary colors, secondary and tertiary. I always have these in my office for people. And always remember that the long strings of neurons that you have in your brain for coping can be broken if you stop engaging in that activity, thought pattern, or feeling pattern. But it takes practice to lay down new tracks. What we find, especially with people with dual diagnosis issues, is that they show up less for treatment and therapy, they struggle with it more, they isolate and withdraw more. And the more they do that, the more long strings of neurons they create for those unhealthy behaviors. So we want to make sure that we openly talk about what's going on. If somebody gets angry or in denial, we want to make sure we go to family therapy and couples therapy to try to normalize talking about what's going on, creating new healthy structures in our brain for laying down neuronal tracks. We also want to make sure that we understand if there's substance use involved, that relapse is really, really common. Relapse rates for the first year of treatment are incredibly high. At 1 year, relapse rates are still 50%. But if you can see at 18 months, it drops down to 30th percentile. What happens here? Well, we know that the brain is starting to heal. When the frontal lobe turns back on, it takes about 18 months. Even at 5 years and more of recovery, our relapse rate is still about 15%, which makes me very, very happy to hear that. I've been sober for 31 years this year, and I know that my relapse chances are still at the 15th percentile, which means I have to stay in recovery and keep working my program and making sure that I take good care of my mental health. Now, here's something that I do with clients is a lot of FOO mapping. So if I work with somebody who has dual diagnosis, one of the first things that I'm going to do is work with them on stopping using. I need their frontal lobe to be on before I start doing trauma work or family of origin work. And I also like to wait until they're about a year to 18 months sober, because I want to make sure that they have a foundation of recovery under their belt so that they don't get stressed from doing family of origin work and seek drugs or alcohol. I also want to make sure that if they have depression that came before the substance use or anxiety, that they are treated for that. I can do that in individual therapy with them. A good clinician can, but a psychiatrist who assesses them appropriately for medication can. We want to make sure that if somebody has dual diagnosis, that they are not on an addictive medication unless they are on a medication that is prescribed by a physician who also knows addiction. For instance, I've got a lot of clients who are in recovery, but also have ADHD. They take medications for that. Most of them are not on an amphetamine-based medication or methylphenidate. What they are on is something that is a stimulating depressant, antidepressant, a medication that doesn't necessarily put them at risk regarding their substance use. Once they are stable and ready to do family of origin work, then I take them and map their FOO buttons. And basically a FOO button is something that is attached to a childhood wound or trauma, big P or little p. We want to find out developmentally what age it came from, what core beliefs, feeling patterns, and coping mechanisms are attached to this wound. For instance, my childhood wound started around age 8 when my mom kept saying to me, "Crystal, how could you do that? What's wrong with you?" Now, I have a distinct memory that she took great care of me. She was a really good mom in many ways, but being hypercritical was what created the wound for me. And I was able to create a core belief based upon that I'm not good enough and that I needed to feel shame and guilt a lot because I was not good enough and didn't do a lot of things right. The way that I learned how to cope was to be perfect and to work really, really hard on not being good enough. So when I mapped my button, I realized that I feel this energy right here in my chest. Many people carry that energy in different parts of their body. So in somatic work, we can work with that knowledge and awareness to understand when the button gets pushed. Because when the button is pushed, we really regress back to the age the wound was created and think, feel, and act it out. And so when we can move out of that wounded kid energy back into our adult self, then we can really start to heal those family of origin wounds, the mental health issues that come with them. Now, as far as genetic addiction risk, this is the company that I use. There are other companies out there. This one does the GARS score, genetic addiction risk score. When you get your GARS test, it will tell you what neurotransmitters, and here are the ones they test for, your genetics tell your body to make less of. What I love is that this company also makes a natural supplement. I actually don't buy mine from them. I just go to CVS and buy it. There's a lot of natural supplements that can actually help increase these neurotransmitters in healthy, natural ways. You can also go to a neurologist to have this assessed. But when you get your report, it will give you what your genetic risk score is for substance use, non-substance addictions, mental health issues, impulse control issues, and personality disorders. So what I love about this is, of course, your genes don't make you do or show any of these symptoms, but they sure do predispose you to that because of what it does to your neurotransmitters. And so this can point you in the right direction and help you validate what you think your diagnosis might be or what your client's diagnosis might be. Okay, so I will share with you my slides, including my references, and a plug for the book that just came out that has a lot of this information in it, the NeuroWhereAbouts Guide. I did put it in the chat earlier, so you can find it. Please know this is a very large book and it is color. That's why it's in the $60 range. But what I want you to hear is that it has scripts for how to talk to your kids about this, scripts for how to teach your clients' parents, and you're working with kids of all ages. There's an elementary, middle, and high school chapter, and a lot of references also available here. Okay, so please take your screenshot now because I'm going to stop sharing so that I can see the chat to answer any questions that you guys might have. All right, I'll stop sharing. And in the chat, so what is the supplement that can help neurohealth? There are many, Susie. So when I found out and got my genetic addiction risk score, I found out that I have low dopamine, and that methylfolate actually helps your body increase dopamine. So I actually just go to CVS and I buy methylfolate there. But it's important that you actually get the genetic test read so that you know which neurotransmitter specifically you're low in. And then a physician or a doctor can help you pick the supplements naturally that increase those. Is the book available in Australia? Yes, it is, because it is published by Ingram Spark that has a printer in Australia. However, I do know that the printer in Australia has had COVID issues, so it may take a little bit of time, but you can get it there. So Julia says, I can understand that someone, oh, we had that question earlier about split personality. Are there any other questions about substance use or mental health issues, you guys? Thanks for the UK. Thank you for attending from the UK. You can buy the book in Canada and in UK. It's available. If you go on Amazon, you will get that. Oh, and there's my email address if you want to look up my website. It'll be available in Audible really soon. And I'm also putting together a clinician's kit and a parent kit that actually has all the scripts and checklists that you'll want as your children grow and develop over time. So watch out, that's coming soon. If you want to get on my my email blast, I will not blast you except when new things and new products come out, unless you would like more information. And you can also email me directly if you have a question or a case that you'd like to discuss about dual diagnosis or anything else.